Debunked, where we analyze healthcare news with a healthy dose of skepticism and debunk some myths from time to time. I am Arundhati Parmar, Editor-in-Chief of MedCity News.
And I'm Samir Batra, the Managing Partner for HIP, a opportunistic healthcare venture fund.
So Samir, Shakespeare talked about the winter of discontent in his play Richard III. We in the healthcare industry are going through the spring of capitulation. I know you're going to say it.
English majors. Why? Why do you have to drag dead guys into the equation all the time?
I majored in English literature back in the day from India. I got to put my literature education to work from time to time. Okay, but why? Why spring of capitulation? So, in these last couple of months, and this has happened just in the last couple of months, we have seen big names in healthcare throwing in the towel when it comes to either virtual care or primary care. Now, as I said, there have been several of those, so let's go one by one. First you had Optum, United Healthcare's Optum. They announced that after 3 years, they're shuttering their virtual care business completely. Now, when reporters reached out to them, they were like, oh, we will provide virtual care, but it'll be part of an integrated care model. So that was one. And then there was Walgreens that basically announced that their Village MD clinics were a bust. They were shuttering all 160 of them and taking a $6 billion write-down of its investment in Village MD.
Ouch. That is a lot of lost candy and cigarettes.
Oh my God.
I mean, they're still one of the ones that sell cigarettes, so...
I guess we have a non-smoker here. Not that I'm a smoker, but I don't have that strong an opinion.
No 2-pack a day?
No 2-pack a day. No. Okay, so by the way, Walgreens, although you're taking shots at them, they're not the only retailer / pharmacy that, capitulated. You had Walmart, and I gotta tell you, I feel that people like me and you that have paid attention to transformation of healthcare industry over time and continue to do so, I think all of us audibly gulped when we heard the news that Walmart was closing its Walmart health business completely, shuttering all 51 of its clinics. And this was surprising because they've actually made a ton of investment in health. So I thought that was super surprising.
Yeah, I mean, 2020, Sean Sylvanski makes big announcements, right? $50 primary care, $25 dental exams, $45 counseling appointments. So there was big hope, right? And main thing also is because Walmart really has access to the part of the population that's hard to engage, right? It's access is an issue there. These small markets, small town America, if you want to call it. So I think the hope was there, right? That, hey, Walmart can figure this out. So.
Well, which leads me to one and only one conclusion. So this idea of let's savvy up primary care with virtual only option, let's divorce it from legacy health systems, let's provide this standalone, this just does not work. I mean, primary care is a loss leader for health systems, but the reason people do primary care because it's a large funnel. It pulls in more specialty care and you make revenue off of that to offset primary care, which is loss making. Now, if you're only doing standalone, no matter how much heft you have, the economics just does not work.
Well, I mean, I think the point that you're making, the tie-in point, right? And I think, so I would sit there and say, first of all, you have to understand, why did retailers get into healthcare, right? So let's just break it down, right? You have to get to the fundamental business focus at the end of the day. So if you're a Walmart, you're an Amazon, you're Walgreens, whatever it is, you care about two things: customers, i.e. volume, and then LTV, right? Long-term value of a customer, right? So you want them to spend as much as possible.
Sure.
Right? So if you fundamentally focus on that part, and then you look at Walgreens or you look at Walmart, for example, what are they trying to do? They're trying to make money. How do they make money? They need more butts in the stores, right? So for Walmart, it's like your metric that you're measuring was like, man, I want LTV. I want people to spend more money, right? And so you decided to go down the healthcare route saying, okay, I'm going to capture more people because I'm going to offer these services, right? But the fundamental problem is if delivering that service, your cost to acquire the customer suddenly goes up, your LTV does not make sense.
Sure.
So volume doesn't matter. But because you're spending more money, that's the fundamental reason why Walmart was like, listen, this is too expensive for us to manage. The cost of care, the cost of acquisition is going up.
Yeah, yeah.
Right? And of course, their issue was around reimbursement, cost, resources. It was all those issues, right? So you're getting people to come in and buy other things and all that stuff, but if it's costing too much to bring them in, then it's just not, a fundamental right part of the business. So if we take that same concept, it applies everywhere, even in hospitals. How do you make money? Well, if you don't have people coming in, right, getting care, surgeries or whatever, procedures, you can't run a business.
Right.
So business fundamentally has to run on volume again, right? So I agree with you. I think the future direction, hopefully, or maybe, you know what, let's just not say this is the right equation. It's the next thing that needs to be tried effectively, right? And the effective trying is that healthcare or hospitals, health systems, payers, whoever the heck it is, they need to reach out and partner with these retailers because their fundamental focus is the same. We need volume. I need customers. I need patients, right? I need long-term value. I need cost of care, cost of acquisition to go down. So I think the partnering strategy of putting a, XYZ ABC healthcare hospital branded primary care inside a grocery store or a retail store, I think it solves hopefully both the problems because then you can leverage the clinical and healthcare brand of the hospital, right, of the payer, right? So I don't know the details, but fundamentally maybe they're the ones providing the resources. They have power from a cost perspective, right? Buying power, as they call it in healthcare, right? And then obviously the retailer has the ability to drive volume, right? Because they're marketing, they're bringing in patients or customers, whatever you want to call it. And then they're winning as well because now those services are being rendered by the hospital or by the partner, right? There's a brand, there's a support, there's a community feel. And then they're going to leave and they're going to go buy stuff before they leave the door. So it potentially sounds like a win-win for both sides. So I think that's probably the thing that I would sort of... And look, there's small examples of this around the country.
Okay.
It's just, I don't know, I haven't seen it in large scale. I have walked into some places, I think in the South and others, you'll be like, oh, look, that's a clinic sponsored by XYZ, that health system in the area or something like that. But I think that could be an interesting thing. So I agree with you. I think primary care, to do it independently alone by a retailer, is just too costly. The resources that you have to deploy, and it's not your core business. Right. Focus on your core business. Yeah. Right. So like McDonald's should not be selling sushi. Right? They should be selling burgers. You know what I'm saying? So,
I mean, I hear you. I think the idea was the whole consumerization of healthcare, and I gotta say, I mean, it was a nice, catchy term, Uberization of healthcare. But I'm gonna debunk that today. I mean, this whole idea of exactly the same consumer models that applied in the consumer world cannot be applied in healthcare. Because why? Because in the consumer world, the consumer is also the payer, right? The model is not distributed where there are multiple judges of what value is and there are multiple payers of that service provided. So this Uberization of healthcare, guys, let's stop it, let's debunk it, let's not talk about Uberization of healthcare anymore.
Totally agree. And one last point I'll make there, and this is something, it's a longer conversation, but I'm just going to tease it.
Sure.
Okay? I think primary care has to go through an evolution. Okay? Just the fundamental focus of a primary care physician delivering care has to go through an evolution. Okay, and so I would also advise when you're sort of doing these sort of partner models. Let's just say this thing actually has teeth, right? This whole provider partnering with the retailer and putting a sponsored clinic, or whatever you want to call it. I think the fundamental focus where we're moving towards from a data perspective, technology perspective, this is a breakdown in our healthcare system, right? We want to focus on preventative and predictive, but guess what? our health system, our government system, our paying system doesn't reward you for preventative or predictive.
Right.
We're a reactive system.
Right.
Oh, you got sick, let me go take care of you. But look, advancements in data, technology, AI are showing that we are going to eventually get there, where we're going to be able to predict and prevent disease progression. Well, then who's still the first person you go to? It's your primary care. Right? But then this guy is just basically, or gal is just triaging care. Imagine if you can equip them with preventative and predictive and wellness strategies, right? So I think they themselves will evolve and have a bigger role, because then they become more than just a triager. They're navigating and they're managing your journey of care. Mention, I didn't say health care, I said journey of care.
Right.
Right? So I think that concept actually appeals more to retailers, because it gives them fundamental more access to things to sell. I'm talking about wellness products, concierge, right, screenings, all that sort of stuff.
Okay.
Where I think there's a fundamental focus also from consumers who can afford it. They will go buy stuff. I mean, I know we talked about 23andMe and the DNA, but whatever it was a one-trick pony. But man, there's a lot of millions of dollars that were made there, billions of dollars, right?
Right.
I think there is a concept, and look, this whole movement with GLP-1 and weight loss, there is this whole area of focus around wellness and around preventative. So I'm thinking, like, even when you do primary care, put that taint on it, right? Put that sort of wellness sort of model around it, right? Yes, it's a primary care. Yeah, it's going to drive services. But I think the fundamental focus of primary care needs to shift.
I mean, I hear you, but I think the problem is that we are not incentivized to promote preventive care, right?
Right? And I think that's the call out to government to sit there and say, look, we need to get into the model where we can't be reactive, we need to be proactive.
Right.
I mean, look, even as an investor, right? Like, I look at companies all day long, and I've been fascinated by some of these companies that have biomarkers, right, and like assays and all this stuff, and they're like, they have a way to get their tests done, right, because the labs are super excited. But the fundamental question I always ask them is, who's going to pay for this? Why would a physician prescribe this test?
Right.
He's not getting paid for it. It's not covered. Insurance is not going to cover it. From a thesis perspective, it makes sense. Why would a payer not want to know what your predictiveness, what you are, maybe going to get? Because they can get ahead of it, right? Because once you get sick,
no, but I'm going to push. I agree with you, but I'm going to push back on that. I think in the model that we have here today with Medicare, Medicaid, commercial payers, employer-sponsored care, no one is incentivized to look at wellness, because, hey, I put all this money in getting you to quit smoking, and then, hey, 2 days later or 2 years later, whatever, if you're good at quitting, you'll quit in 2 days, but more likely several months or maybe a year or so, you switch jobs. And so all the benefits of your good health is now being experienced by a different employer, while I didn't. So this it's nice to talk about wellness and prevention. Our system does not value that.
I 100% agree with you.
Yeah.
So I'm not sitting there saying that that's not an issue.
Yeah.
I'm calling that out as an issue. And if we want these things to happen, if we want these, smoking was a big issue. But the fundamental thing is, figured it out that, hey man, who probably out of payers would want preventative? I want to keep you healthy. I mean, it's like things like Whole Foods would give their employees larger discounts based.
Right.
But
Absolutely.
I'm just saying.
Right.
And there is still a there that will buy that stuff,
Right.
even if it's direct out of their own pocket. They care enough to sit there and say, "It's $100. Yeah, I'm gonna go pay for it." If it tells me certain data points that I can then change my life around,
Yeah.
I'll pay for that.
No, I hear you. There are people that will pay for that, but I wonder if it's a critical mass that will shift how healthy our nation is and bend the cost curve. But moving on from that, let's actually not moving on. Let's just go back to what we were talking about before, which is virtual care and primary care. We talked about primary care. Let's talk about virtual care. And I feel like there's more and more evidence out there that virtual care that's standalone doesn't really work. I'm seeing, in the stock prices of Teladoc and Amwell, now they're much ahead than startups in the field, of course. There is no value that the market is giving to stock of Teladoc and Amwell. And I think virtual care only survives as a part of a healthcare delivery system. It is not a standalone product. What do you think?
Yeah, this is going to be a very short conversation because I totally agree.
Okay.
Right? There's no point to argue this. Absolutely, it does. I mean, even when you said, right, Optum said we're shutting down their virtual business. But what did they say? They said it's going to be available, right, to like our members, right? It's going to be available to our members, but we're just not going to have a standalone business focusing on it.
Right.
Look, and I'm an advisor for ATA. I'm a huge proponent of virtual care and telehealth. But guys, telehealth, virtual care, whatever you want to call it, it's a commodity now.
Right.
Okay? It's a means to an end. It has to be part of the patient experience. You cannot build a standalone, isolated telehealth solution and expect to have massive return on investment and growth. I'm not saying that or if your strategy is to go build one, you need to go partner with digital health provider. Because look, every digital health solution now sits there and talks about, telehealth is like not even mentioned.
Right.
It's like Roe, Hims, they all do telehealth.
Right.
But is that their fundamental business? No, they want to sell you pills and supplements and tests, right?
Absolutely.
But the virtual care is like, oh yeah, it's a bolt-on. Right? You're paying for that, you're going to get a virtual consult. So again,
it's a modality.
It's a commodity. It's not a standalone.
Right.
So it's just and then you're like you said, with these two stocks, they've hit their peaks, right? They've hit their plateaus. And even if you look at places like that, there will be consolidation.
Yes.
And the only way to survive there is, I just gobble up all these guys because I'm buying market share. And then I know I'm a low margin business.
Right.
And I'm not a sexy business, if you want to call it. So totally agree.
Okay.
It is a commodity.
Yep. Okay. All right. So now finally moving on from virtual and primary care. We just concluded our Invest annual conference in Chicago. Samir, you were there. And what I try to do as the, sort of content creator or the program director, whatever you want to call it, for the conference is that for our fireside, I try to invite someone who has a perspective that is relevant in the healthcare industry at this point of time. So this year, I was very fortunate and honored to interview Nitin Natarajan, who is the Deputy Director of the Cybersecurity and Infrastructure Security Agency, CISA, which is a government agency. Given all the things that's happened in healthcare, his perspective was really interesting. And what he said was how his world has changed since these major attacks. Previously, CEOs would not really think that much about cybersecurity. They would probably think it's the domain of the CIO or the CISO, whoever, but not them. But now he's saying that more CEOs are talking about cybersecurity in M&A discussions. They're using terms like attack surface. So it seems like CEOs in the C-suite fully understand what a risk cybersecurity attacks can be to not only their reputation, their operation, everything involved.
Yeah, so glad you had him, because this is not just a single isolated issue anymore, right? It needs to be a major part of the government's healthcare strategy. So, if it wasn't true before, it needs to be. So having him say that was really good.
Yeah, and we've been writing about it, and recently our Katie Adams interviewed 5 or 6 senior hospital leaders about how they're responding to this environment where cybersecurity and cyber attacks are almost inevitable. And she spoke with Robert Bart, who is the Chief Medical Information Officer at UPMC, and he had something interesting to say about government involvement. And I'm going to read from my notes here, because I don't want to mess it up. This is what he said. When we moved to electronic health records, there was federal funding that underwrote the adoption of those systems, the HITECH Act under the Obama administration in 2009. Maybe there needs to be something similar that underwrites the adoption of industry-leading cybersecurity for healthcare. So in other words, what Mr. Bart seemed to be suggesting is that the U.S. government see this as a national security issue and pump money into it because, there's obviously this push and pull between industry and government in terms of how much government involvement you want to have in healthcare or any other industry. But it seems like without that, we're going to have a patchwork of rules where, some hospital systems with more cash or entities with more cash will be able to invest more, while others will not. So should the government be involved, Samir?
I love this!
Oh my God. There you go.
I love it because you remember I talked about the CSA. Okay?
Yes, the Cybersecurity Security Administration.
Yeah,
yes.
we're going to get back to that, okay?
Okay.
But this completes the picture.
Okay.
So I'll explain. Look, so as an entrepreneur investor, right, I want the government to make it easier for entrepreneurs to build businesses.
Sure.
Right? And for me as an investor to invest in them, right? But on the flip side, right, if you look at our healthcare environment, it is really difficult to build a successful business, right? It's so fundamentally hard to get into these providers and payers, right? So look, there's two sides of the equation here.
Okay.
And what, your guest talked about at the show and Katie's interview with the CEOs, they're fundamentally talking about the other side of the equation that I was mentioning. So if you're going to go tell providers and payers, hey, listen, carrot and stick, just like we did with the EMR, right?
Okay.
Carrot and stick, right? You're going to get rewarded for meeting stages, or you're going to get penalized for not meeting the standards.
Meaningful use it was, right?
Meaningful use, right?
Yep.
So look, people bitched, moaned, complained.
Right.
Okay? Oh, they dragged through it.
Yeah.
Now they can't freaking live without their EMR.
True.
They might still hate the damn EMR companies, but they can't live without it.
Right.
So, same thing. Government does need to step in and say, look, here are the standards that you need to meet for cybersecurity. Clear, like you're going to be carrot or sticked.
Okay.
Okay. But if you do that, so that's happening from a provider and payer perspective, right? Okay. So I'm sitting here. Okay, I know that this is what I need to do, and I need to invest in this. And if I don't, I'm going to get penalized. If I do, I'm going to get rewarded. Right?
Okay.
Great. Okay. Now you fundamentally answer the other side of the equation for them and say, so now a provider payer goes, all right, I know the standards. I know what I need to do to make money, to carrot and stick, right? Lose or win. Well, damn it, I need to go find vendors now that meet those standards. Aha. Now CSA is back in play. Because at that point...
Well, hold on one second. Explain
yeah?
what CSA was for people who didn't watch your previous episode.
Cybersecurity Administration Agency, whatever you want to call it. Basically, it was my sort of version or example of like what the FDA does with devices or drugs, right? Hey, listen, you have to meet certain clinical validations and standards, and we're going to approve you, and you're then allowed to go sell to providers.
Okay.
Right? You can't go sell a device that's going to go, be in clinical care, right, without an FDA approval. So similarly, now if you create these standards for cybersecurity that the providers and payers have to meet, well, hell, as a vendor, as an entrepreneur, you need to meet those standards so you can gain that business. Well, who's going to measure you? So you need the flip side of the equation, right? Government agency, whatever it is, whatever protocol, I don't care.
Yeah.
Right? You don't have to call it CSA. Give me the credit.
He's being generous. You don't have to call it the CSA.
Right? But the point is that the innovators need to know, hey, look, I need to get on this approved qualified list.
Yeah.
So then I can go deliver this book of business and gain that business, right? Because then you're turning cybersecurity, and look, competition, what does competition create? Better solutions, right? And so it's a fundamental way where the government ends up, look, call it like it is, right? We talked about it, hey, we need payment reform and stuff. Look, you got to live in the pool that has been created for you.
Sure.
Government is what it is, okay? We ain't going to change it anytime soon. So if that's the case, government, help us get there, right? If you're going to put those standards in for the providers and payers for them to meet, you got to give the vendors, the entrepreneurs, direction in terms of what standards they need to meet.
Okay, so I hear you, and it makes logical sense, but I want to clarify a little bit. When you say vendors that are trying to sell into health systems, are you talking about any vendor selling any product or only cybersecurity products?
Right now, just cybersecurity.
Okay,
right?
All right.
I'm not questioning other things. That is gonna limit innovation.
Yes.
If we start doing that.
Yes,
and
agreed.
I'm a capitalist.
Yeah.
I'm an entrepreneur and I'm an investor. But cybersecurity, you can't just mess with willy-nilly.
Yes.
Okay, United Healthcare can tell you, Change can tell you, there's
well, I mean, they didn't do multi-factor authentication. It was
totally
a simple enough thing, right?
I mean, I literally, like, probably on a monthly basis, through my news feeds, I hear about cyber attacks.
Right.
Provider organizations.
Right, it's inevitable.
And most of them are like so small, they're tiny, you don't hear about them. But they're constant.
Yes.
Right?
Yes.
So my whole point is that I'm not trying to govern or mandate or protocol all innovation and technology. But you can't mess with cybersecurity. I'm sorry. Like, there's just too much at stake.
Yes.
And you even said this, and other people have said this, it is a national security issue. Okay? So if it's a national security issue, I'm sorry, like, you need to be qualified to have a solution, right? I'm not trying to sit there and say, look, even AI governance is coming, okay? But my point is, with cybersecurity, you have to control both sides of the equation or the marketplace. You got to tell providers what they can do and can't do, award them, penalize them, and then on the entrepreneur and innovation side, there have to be certain standards, right? Because if they're just building crap and there's no standard for the provider, and if they're great salespeople, they're gonna get the health system to buy it.
To buy into it,
right?
sure.
They don't care. And so, how are you going to control that? There's got to be a certain way to control it. It's the same thing from the device perspective. I could go create a device and get, uncles and aunts to sit there and say, oh, this clinically works great. And I show up at a hospital and I put it in.
Yeah.
Right? If there's no controls, if there is no FDA, then who should believe who?
Yeah.
Somebody has to sit there and be the person who sits there and says, okay, yeah, you know what, you did this right.
Right.
I think that has to happen on both sides.
Well, I mean, I think that makes sense. I think what I am curious to see is that this is not going to happen overnight. In the meantime, what happens? I mean, one of the senior C-suite leaders that Katie interviewed, actually, and I'm forgetting his name at this moment in time, but he actually said that yes, your hospitals are cash constrained. They're looking at places to cut. Cybersecurity should be off limits.
Yes.
As a place to cut your expenditure.
Well, and the last point I'll make there is, I have a hard time believing that this won't be a bipartisan thing that they will agree on.
It will be bipartisan.
Okay? I mean,
I think so.
It's fundamentally true. The government spends and has programs out there. This is why healthcare innovators get excited. Look, if you're going to go start a business, the first thing sometimes people do? Go look at what new laws have been passed.
Right.
Go figure out a business to build to solve a problem that the government is validating, because they're sitting there going, we're going to give millions of dollars to providers to go do this. There's more money out there than there is providers who are taking advantage of them. Let me just put it that way. Right?
Okay.
Right, in terms of these models. Just even recently, there's a program that got rolled out called GUIDE.
Yes.
Focused on dementia care, right? Now you're going to see a floodgates of companies building out dementia care models where providers are sitting there going, I'm going to go get a tech-enabled service. I already got the dollars from the government to go spend it. So fundamentally, they're selling to the provider, but who's paying for it? Government.
Yeah.
Right?
Yeah.
So I think there's a way to get to this. And look, is there a balance and there's a give or pull? Yeah, I'm sure there is.
Yeah.
Right? I'm sure there is. But I think it's proven that cybersecurity has a long-lasting impact on all these things. And even as an investor now, I'll tell you, I have a fundamental question on my list now with every entrepreneur that I talk to that is very data-centric. And I sit there and go, what's your cybersecurity strategy? I'm starting to ask that.
Okay, sounds good. Okay, just taking the thread from that part, we're going to move to our favorite part of the show, which we don't do as often and not in every episode, but it's the Ask the Journalist and Ask the Investor. So I'm going to start. asking the investor here, Samir.
Sure.
You know, health tech investment is going through a shakeup.
Yeah.
Are there any product types or healthcare sectors that you no longer want to invest in compared to maybe 5 years ago?
Yeah, I mean, I think it's a add-on to our earlier conversation. Standalone telehealth, don't bother calling me. Okay, I'll add to that one. Standalone RPM, don't bother calling me.
Okay.
So I think both these sectors, I think telehealth, the conversation has been long talked about.
Yeah.
Right? But I think RPM is there too now.
Well, I don't understand that. Didn't CMS last year provide actually some codes for reimbursement for RPM products?
There's tons of RPM, RTM codes out there. That's not the problem.
What is the problem?
The problem is that the engagement around an RPM solution does not have, from a venture perspective, it's not a investment worthy business anymore, because what ends up happening is that you engage a provider, right, and they get on board, and now I'm going to go sit there and attack the consumer, us.
Okay.
We live in this technology role. Oh, look at that shiny thing over there. Oh, look at that shiny thing over there. Look at that shiny thing over there.
Yeah.
And that's, so how can you, so RPM requires the patient, okay, and a lot of RPM solutions are focused on chronic patients, right, obviously. You think grandma, grandpa at 65, 70 years old, 80 years old is going to remember to use that Bluetooth-enabled, you know, monitoring cuff or whatever constantly? No, what's happening is you look at the data, engagement starts off like this,
Okay.
and then it just
Plateaus.
right? So that's
It's a Fitbit situation. They abandon using it, or do they?
They just forget, they abandon, because guess what? Because a lot of providers in RPM walked in. So the first fundamental thing was they just took a bunch of devices, connected them, put them on a platform and said, yay, we're going to push the data into the EMR. That was the first wave of RPM. Second wave of RPM was they figured out, oh crap, this doesn't work because it's plateauing. And the smart ones that are still around, they turned it into a tech-enabled service.
Right.
Meaning you need a care management element to basically engage your patient.
So like Medically Home, for example, the one from Mayo Clinic.
Right, but the point was, it's like, okay, so now you have these patients using the device, you need to call in and check in on them.
Right.
Hey, you know, Mrs. Smith, like, how's it going? Oh, don't forget to transmit your data. I need you to go ahead and...
So reminders, kind of like coaching them to do something.
Coaching them along, but even a tech-enabled version, but also a low-tech version. Look, healthcare at the end of the day, you still fundamentally need to have a human-to-human interaction.
Right.
Okay. So then when you enter the tech-enabled model into RPM, your margins go down.
Right.
Your margins go. Now you need a lot of volume.
Yeah.
So, but then in RPM, everybody and their mother was launching an RPM company.
Right.
Okay, because it was so quick. If you had really smart developers, you can stand up an RPM platform in like probably 2 weeks of coding. Okay, a couple of weeks, boom, you got the platform up and running, right? So you had you had this influx, volume of RPM, and they're just littered out there now. Now, I'm not saying that there aren't a couple of people who are sort of like, you know, leading or whatever, but if you're standalone RPM,
that's it.
You're going to have the same fate that telehealth standalone is going to have, right?
Wow.
If you're primary care, it's not going to happen.
Interesting.
Right? You need to be an embedded solution. You need to be doing more. I'm not going to mention who it is, but we have a company that we've invested in that RPM is part of their equation. It's not their fundamental core business.
Okay.
And it's also a business that gets reimbursed for services from the government, for Medicare. There's other codes that they're using, and they're piggybacking and taking advantage of RPM as an add-on.
I see.
Nowhere on their website they talk about RPM. So I think RPM is another one of those. It needs to be embedded. It's going to be a commodity, right? And you're starting to see it happen, even from the big companies and from smaller companies that are building solutions. Look, the device companies, that's another model that they have, right? You have a device, and if you're a device that can be at home, you still have to be FDA approved,
right?
So you're going to have a prescription, you're going to have all that, and then you just slide in RPM underneath it. It's an add-on. It's not your main revenue stream. It's an add-on revenue stream. It's always going to be there. It's always going to be available. So there's my ask the investor thing. If you're an entrepreneur and you want to start a business, do not start a standalone RPM business or telehealth business. And if you are one, just do me a favor, do yourself a favor, don't call me. Okay, just don't call me.
This is one mean investor.
No, I'm just trying to save people time.
Yeah.
So,
no, I hear you.
Let's flip the script.
Okay.
Journalist. So I read or try not to read a lot of stuff around AI, but I can't get away from it.
Right.
So what's your opinion on all this stuff? Well, how are you guys approaching writing about AI and everything?
Writing about AI or how we look at AI written stuff?
Both.
Well, writing about AI is easy. We get pitched a lot. So we were publishing a lot of articles, contributed pieces on artificial intelligence. They were all very general. So now my rule is, all right, you want to talk about how AI can help in patient experience? I need specific examples. Now, it's a little bit hard because the contributed program is editorial content. You cannot write about your own products or your customers' products or how your customers are using your products. But you can talk generally about an area within healthcare that is having a specific outcome because you're using AI. So we're looking at writing about AI from a very what's the right term? Very specific way. We want specific, narrow examples, not large conversations about, oh, here are 5 ways that AI can help in healthcare.
Yeah.
The bigger challenge is AI written content, which every publisher is dealing with, and I'm at a loss, honestly. What we've begun recently, I detected our first AI written story, contributed piece. You know, we have the MedCity Influencers program where anyone in the industry is welcome to write for us using our set of guidelines. We had no specific guidelines against AI, assuming foolishly that people were just writing, like I write my own stories. But what happened was there was one particular story that seemed very glossy. I don't even know how to describe how I realized that this article was probably written by AI. Perhaps because the author I knew had not a huge, strong grasp of the English language, and yet this was every sentence was super polished, not specific, but very general, but very correct. And so we have an freelance contractor that basically processes these submissions, and I was like, hey Karen, can you take a look at this? I really feel that this is AI generated. She, the smart woman that she is, she went and ran the piece through an AI generated, not AI, those AI engines out there that can detect, and it came out as 100% likely written by AI. Obviously, we told the person that we're not going to be able to run this piece again, and so now we have made it a clear guideline that we do not accept AI generated content. What is happening is PR professionals that are normally hired to interact with folks like us and push certain ideas, certain stories along, they are using AI and finessing the piece. And so, of course, our engines are detecting them and saying, okay, we can't use this because it's generated by AI. So I'm at a loss. I mean, I feel, look, I personally have used AI to research answers. I do go back and double check stuff that I read on ChatGPT. If I had a question, I will go back and check the original sources. But you cannot produce an article with ChatGPT or have it finessed by ChatGPT because our engines will detect it. And so if you are hiring a PR professional, please tell your PR professional that write it or fix the errors yourself instead of running it through an AI machine, because it'll come out as 100% written by AI the moment they do that. First of all, if I were the author, I would be pretty upset that my PR, contact is using AI to fix issues. I think they're doing it from an efficiency perspective. Most people want to use AI because it's efficient. But you know what? It's not human. It's not correct. I mean, your PR people should know enough grammar to be able to correct your pieces. So please, if you're the PR agency, know our policy. Please do not put the entire article through an AI engine and then send it to us. It will get flagged. It's not going to get published. And if you are an author for us, please tell your PR professionals, make sure they know their own grammar. That's all. English is not that hard.
I'm so glad you said this, because I think, and I want to know about those AI so an AI to detect AI. I love that, because I think everybody needs that, even from as an investor perspective, right? And I think you're right. I think it's a tool. It needs to be an aid. It cannot be. And I'm not obviously an AI detection machine, but when I see a lot of glossy words and everything just seems to fall together too perfectly, you're like, dude, somebody else wrote this.
Yeah.
So,
yeah.
but I mean, look, we even in our business use AI to comb through our pieces. But at the final product, you know, it's so funny. I take product that gets filtered through a chat GPT or something, and I get it, and I go, dude, but I don't write like this.
Yes.
And I literally take that, and then I edit it. So I'm like the AI's editor. Like,
I've done that too. I mean,
right?
for conference sessions, sometimes I'll have an idea and I'll have the AI write it, and I'm like, but I
not how I
re-edited.
write.
And that's not how I write. Exactly. So do that, people. Don't just. I don't know. Maybe I'm old-fashioned. There will be a time where everything is going to be AI generated.
Give me a bot.
Yeah, there'll be a bot. I'll be a bot. But as of now, in 2024, we can't accept it. If you haven't followed us, please follow us. Please subscribe to our YouTube Debunked page and watch our previous episodes. Share it with your friends. We're wannabe healthcare influencers.
Yeah.
So please like and subscribe and share. Thank you so much.
And please tell us if you don't like something or you like something. Don't be shy. We're not.
Write to us at debunked@medcitynews.com. Thank you.
Thank you.